Hello and welcome. Welcome to today's session. You are here with the National Hispanic and Latino PTTC and the Northeast Caribbean PTTC at Building Culturally Inclusive Coalitions. What do equity, inclusion, and diversity mean when we all look the same? We're going to give folks just a moment to come into the room, and then we'll get started. Thank you for being with us here today. We're very happy to be here with you, and we're glad that you've chosen to be here with us. And we'll get started. All right, so welcome again. You're at Building Culturally Inclusive Coalitions. What do equity, inclusion, and diversity mean when we all look the same? Today's session is being presented by the National Hispanic and Latino Prevention Technology Transfer Center in partnership with the Northeast Caribbean Prevention Technology Transfer Center. My name is Claire Neary. I'm the project coordinator for the Northeast Caribbean PTTC, and I'm going to be sharing just a few introductory thoughts. So firstly, we want to acknowledge our grantors, the Substance Abuse and Mental Health Services Administration of the United States Department of Health and Human Services. We will be sharing out these slides. So there's a lot of information on this particular slide, and we'll be sharing out these slides to you after the presentation, and we'll let you go ahead and review this information at your convenience. We want to take just a moment and reflect on the power of words. We are all prevention leaders in our teams, in our community, and in our field. And together we can use words to create positive change. A little bit about the PTTC network. The PTTC network is a multidisciplinary resource for prevention professionals throughout the United States. The network is comprised of 10 domestic regional centers, 2 national focus area centers, and a network coordinating office. The National Hispanic and Latino PTTC is associated with its parent organization, the National Latino Behavioral Health Association. And NLBHA's mission is to influence national behavioral health policy, eliminate disparities in funding and access to services, and to improve the quality of services and treatment outcomes for Latino populations. NLBHA's objectives include targeted capacity expansion of mental health services for Latinos, Latino behavioral health evidence-based practices, legislation to increase the number of counselors and therapists and other behavioral health practitioners, funding for co-occurring disorders of alcohol and substance use, opioid crisis considerations in the Latino community, and suicide prevention. The National Hispanic and Latino PTT staff includes Dr. Susie Villalobos, who's the project director, Priscilla Giamasi, who's the project coordinator, and Cristina Mancibo Torres, who is the project specialist. And you will be hearing today from Priscilla Giamasi and Cristina Mancibo Torres for today's event. The Northeast Caribbean PTTC is located at the Center for Prevention Science at Rutgers School of Social Work. Our director is Kristen Gilmore Powell. Our co-director is Andrew Peterson. I'm the project coordinator, and also assisting in this work is Corey Morton, who's our investigator, and Emily Maykoff, who's our data manager. We are also assisted in this work by a wonderful group of substance abuse prevention specialists at Education Development Center, including Shannon Cassidy and Ivy Jones-Turner, who will be doing the session with us today. A little bit of housekeeping before we get started. You will be getting a copy of the presentation at the end of the session. This session is being recorded and will be being shared out with all of you. There will be a Q&A component at the end of the session, so please keep track of your questions, and also please feel free to put them in the chat box. We will endeavor to address them in a timely fashion. We're going to be asking you to do an evaluation at the end of the session, and I want to really make a request that you endeavor to do the GIPRA survey that we'll be asking for. It's the way in which we are able to give feedback to our funders at SAMHSA, letting them know that we are able to bring quality services and presentations to all of you. We'll be sharing out certificates of completion at the end of the session, and there is closed captioning available on this event. And if you have any difficulty in accessing it, please just let us know in the chat, and we will be there to support you. And now we are going to get started with my colleague, Priscilla Giammassi.
Thank you so much, Claire. Can you move on to the next slide, please? We just want to welcome everyone again and thank you for joining us on today's session. We are very happy to have you with us, and we are excited to start this conversation, to continue this conversation actually. And before we start our training session, we just wanted to give you a little bit of context about this training. The four of us, Shannon, Ivy, Christine, and I, we delivered a presentation at the NPN conference last year. And the session was titled, "What Does Diversity Mean When We All Look the Same?" And I hope that you had the opportunity to attend the live session or to watch the recording. If not, we will be sharing the link with you so you can take a look at it. We delivered a session last year and it was only 1 hour. And we realized that that was not enough time to cover this topic. There were a lot of questions that we were not able to answer during the live event. And we just wanted to make sure that we can cover the subject, because we know that this is a much needed conversation that we have to continue to have. So we also wanted to give you the opportunity to ask questions and to have more time to learn with each other. So with that in mind, we are hosting today's session specifically about diversity, equity, inclusion in the prevention field. And we will also be offering special technical assistance sessions for a closed group, and we will give you more information about that at the end of this presentation. On the next slide, I do want to remind you about the goals of today's session. These are our learning objectives. We are hoping that we will be able to provide you a deeper understanding of culture, diversity, equity, inclusion, and related concepts of identity within coalitions and communities. We want to discuss how we can read health equity data and identify community assets. We want to review tools to better understand the communities that you are serving right now. And lastly, we want also to review how can you implement D&I initiatives in the real world settings. On the next slide, if you watched our session at the NPN, you already heard a little bit of these definitions, but we want to review them briefly with you today. When we talk about diversity, diversity includes and involves individuals with varying demographics, values, and lived experiences based on race, gender, sexual orientation, class, age, country of origin, education, religion, geographic, physical, and cognitive abilities. When we value diversity, we recognize differences between people, we acknowledge these differences as a valued asset, and we strive for diverse representation as a critical step towards equity. Equity is the presence of fairness. You can go back to the previous slide, Claire, please. Thank you. Equity is the presence of fairness, impartiality, and social justice for individuals and communities. For example, in the healthcare system, equitable practices prioritize the distribution of resources and processes that drive a particular kind of health inequity. And inclusion refers to the process in which individuals with varying identities and cultural backgrounds have equal access to information and are valued, welcome, empowered, to participate fully in the life and decision-making processes within an organization. Inclusion involves authentic and empowered participation with a true sense of belonging and full access to opportunities. On the next slide, we just want to share with you this image to provide more examples about how equity takes place. If you look at the picture in pink, you will see folks from different genders, age groups, race, ethnicity, physical abilities. You see that there is a diverse group in the image trying to cross the road, and each of them are facing their own challenges in doing so. The next picture on the right side of the screen in blue, you will see the same group of people crossing the same road. However, now they have the tools that they need in order to, in this example, to cross the road in the best way possible for each of them. The step that was a barrier or a challenge before was replaced by a ramp. There is also sounding and visual system in place to provide individuals with a better and safe ways to cross the road. So again, equity is to provide resources and other processes to address a particular kind of inequity. On the next slide, we want to share with you the wheel of power and privilege. When we talk about issues of equity, we usually talk more about race. However, there are other elements that play a role in our society's norms and values. These are the groups that experience power and privilege when compared to other groups that are marginalized. We have some examples here in this slide. We will not be able to cover all of them today, but I do want to highlight some of them with you on the next slide. When we think about gender, cisgendered men are the group with more power, trans, intersex, and non-binary with lower power, and cisgender women are the group in the middle. So I identify as a cisgender woman, and I face discrimination and inequities because of my gender. Language, native English speakers hold more power over those that are non-English speakers or monolingual individuals. So English is not my first language. You probably noticed because of my accent. I am Brazilian. Portuguese is my first language. So in this example, I have more privilege compared to no-English monolingual speakers. Thinking about my people, only 1% of the population in Brazil can speak English fluently. But I have less privilege compared to a native English speaker. When we talk about citizenship, citizens and documented people have more power and privilege than undocumented people. I was waiting for my green card for a few years. I finally got it last year. But while I was in the process of waiting, I could not leave the country. So I waited more than 3 years to be able to see my family and friends back in Brazil, because I didn't have the privilege at the time of leaving the US and returning safely to the home and to the life that I was building here. And lastly, skin color. Historically, white people are the ones with more power and privilege. Within our communities of color, we also experience colorism, which is the lighter your skin color is, more privileges you have. As we saw in the previous slides, besides race, there are other things like gender, physical ability, age that can impact the way that we experience life. There are other forms of power and privilege that are missing in this wheel, for instance, religion. Besides the power and privilege nuances, we should also think about the intersectionality, which is the cumulative way in which the effects of multiple forms of discrimination, such as racism, sexism, classism, combine, overlap, and intersect, especially in the experiences of marginalized populations. Our hope is that we will keep talking about these issues and finding solutions to improve the systems that are in place to benefit our communities. Today, we want to encourage you to learn more about the community that you are serving and the people that are working with you. Once you know more about them, their background, and the ways that they identify, themselves, you will be able to improve the quality and the impact of your prevention efforts. One way of moving the needle into that direction is to think about how we collect data in our coalitions, in our prevention programs. And Ivy now will continue this presentation and discuss more about data collection.
Thanks so much, Priscilla. At this point, what we'd like to do is talk a little bit about data and how data plays into our understanding, not only of power, privilege, presence, but also in terms of our understanding and planning for prevention efforts. So with our data collection or with our prevention efforts, one of the key things that we always do is to conduct a needs assessment. And with that needs assessment, you're looking to understand several things about the data. You want to know, what is the problem? Where does the problem exist? What's the magnitude or size of the problem? How many people are affected by the problem? What are the consequences of the problem? When does the problem begin? And so on. What we want to encourage you to think about as we're talking about data is to think about how broadly are you collecting data? In particular, if we take a look at some of the data sources, we could, I think, very easily identify and have the chat flooded with sources of data that you're using. Very often, a lot of times, this is what we begin with in terms of what we call primary data sources. We have it for an example on screen. You see archival and quantitative data. Looking at data sources that are already collected by other entities that helps us to understand what is the population and some other key baseline data. You'll see as the last couple of examples, in particular, data from the Department of Education. That's going to include not only maybe some information about academic performance, as well as academic failure of students, but you'll also understand a little bit more about what is the size, the demographics of the student population, etc. With the vital records, that gives us an opportunity to understand a little bit more of maybe if there are overdose deaths, what's the information in terms of the substances or the situations that may have preceded that. I think you'll also note that the last couple of examples are data sources that you probably are already collecting and have access immediately to. That is your youth survey data that may be collected on an annual or a biannual basis, whether it's the youth risk and behavior surveys, or maybe it's the communities that care or some other surveys. You're collecting information from youth. And then as well, you have maybe some very local survey data where you're finding out more information in terms of consequences or in terms of behaviors and attitudes of participants. And then below, we also see some qualitative data, and we're always encouraging the thought and perspective of enriching quantitative data with qualitative data. Qualitative data that allows us to understand a little bit more than can be answered through maybe a simple quantitative closed-ended response or Likert scale survey. And so that is conducting those key informant surveys or those key informant interviews and discussions, focus groups. They may be with some of your community partners or key stakeholders within the community who can enrich an understanding of the quantitative data. Hopefully, many of you are already including some of the qualitative data as part of your needs assessment. There's also, I think, an opportunity that we encourage thinking about in terms of this third category, which is going to be your local survey data. And this is where you can use your local surveys to add both an understanding from the quantitative data that you've already collected, maybe through some of your other partners, maybe through some of the other data sources, also enriching with information from your key informant surveys and the qualitative data that you've collected through focus groups to really look at some of your local surveys. And many of you are probably already using local surveys to find out more information from partners, from individual participants as well. Here are some suggestions that we've noted just in terms of thinking about how to best include or how to ensure inclusion of a broad group of participants for those surveys. Making sure that the surveys, of course, are shorter, but also that there is an opportunity to really hear from, as Priscilla just noted a few minutes ago, not just those who might be our favored populations, i.e. those who have ease with completing online or written surveys, so no visual impairment issues, those who may be unfamiliar or less familiar with English, so making sure that those surveys are translated, and then of course just making sure that the literacy level of those surveys is accessible to as broad a population as possible. And of course, we recognize that's where it's so important to pilot those surveys. Don't create them in silos, but ensuring that there's a broad group of partners who have input and feedback that they can share with you on your surveys. But then, of course, as we're thinking about all of these data sources that we're collecting, whether it's quantitative and qualitative, looking at the magnitudes and the size, as well as the consequences of substance misuse problems that may exist in your community. As we go to our next slide, there are a couple of additional questions that we really want to encourage you to think about. And that is recognizing that data always tells a story, but you also want to ensure that you're understanding, is there bias present in the story that's compiled from that data? Several questions that you might want to consider are, how was the data collected? What was asked? How was it asked? And when was it asked? And that allows you to begin to look at maybe some of the bias that exists in the questions themselves. Are we asking data in terms of how the data being collected? Are we looking at data that comes just from one population or one audience? So for example, we're very often in our needs assessment data using surveys that are compiled from young people. Is there an opportunity to collect data from adults and from others within the community who may have some input? And this is where some of your local data collection is very helpful. As you're thinking about some of the data that's collected, what's being asked? Very often we recognize that in our surveys, we're asking about we're asking about risk behavior very often with our youth surveys. But are we also looking at protective factors or positive behaviors? For many of you, you've heard of the Communities That Care, or maybe the Search Institute's developmental assets. There are a whole host of different data indicators that we've looked at over a number of years that help us to know not just risk factors, but also some of the protective factors, some of the positive behaviors, some of the knowledge that may be possessed by a population that we're surveying. And so this is where we want to encourage you not only to look at the risk behavior included or risk questions included in your surveys, but also look for some of that positive information, some of those protective factors. We'll also encourage you to think about some of the data sources from which information is being collected. How many of you are actually collecting data from key partners in the community, such as law enforcement or health and other partners, health agencies and other partners? With that data, does that include arrest records? Does that include arrest records? Does that include overdose information? Does that include details in terms of the demographics of who may be experiencing consequences? And so what we're going to encourage you to think about is some of the data sources will particularly focus on risk behavior or look at information on populations at a particular perspective. And so you want to look at what and how is the bias present in the data that's being collected from those entities. It doesn't mean necessarily that you end collecting data and sharing data with some of those partners, but instead you may want to balance that data with additional data sources and data that's being asked. And then, of course, also looking as well at some of the outcomes of the data. Is the data that is being asked in terms of some of the collection, is there bias in terms of the outcomes focusing primarily, again, on risk factors? Does it also include protective factors? Does it include positive behaviors? Does it include information that may represent strengths and assets that are reflective of multiple cultural experiences or backgrounds? I think for many of us, we would also note that over the last several years, particularly with some of the racial reckoning, we are reassessing some of the data and understanding what data was collected 15 years ago, 10 years ago, and how that data, same information that we might be looking at, how we're asking the data, how we're asking the questions differently as we collect the data more recently within the last several years. Particularly for some of your youth surveys, you're looking at including more sexual orientation or sexual identity. You're also looking at including more information about some of those assets that may be identified. Where are you where are you finding opportunities for support and assistance? These all are part of how data tells the story of a community or a population or a city in terms of where are there consequences, where are there problems in terms of substance use, but then also where and what are the resources and supports that exist. So as we've been thinking about some of this, I want to move us to our next slide, and we're going to show a brief video that helps us to begin to think about where and how we might begin to parse out or separate some of that data. In particular, we're going to introduce the idea or concepts that you've probably been speaking to of the social determinants of health, and recognizing how different factors in our data collection may allow us to understand how social determinants of health not only appear in our data, but also how they're impacted by our data. We're going to be speaking specifically to 5 concepts within social determinants of health, and that those include economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, as well as social and community context. And so as we begin the slides, as we begin the video, we'll have an opportunity to hear how they all appear
Ivy,
in the life of one person.
Sorry, please let me know if you can see the video and hear the audio.
So not just yet.
Okay. Sorry, everyone.
You heard it.
Yeah, but we don't have our IT person here today. He's having some time off. So we're gonna figure this out.
Yes, we will. I see a question in the chat box about, yes, the presentation will be shared out at the end. We're recording it, and you will receive both the recording as well as the slides themselves.
I don't think I can share, Shannon. Are you able to?
1 second.
I can.
Sorry.
Give me 1 second.
Sorry.
Oops.
And
Okay, here we go. And I will just warn you, I do love captioning, so you will see captioning on, but that's just my personal preference. Here we go.
To best grasp the political determinants of health, let's examine a hypothetical example that combines experiences of real people in urban and rural communities. Imagine a 19-year-old woman, we'll call her Jessica. After enduring several miscarriages, she barely survives giving birth to an infant 9 weeks early, the baby weighing only 3 pounds. Her son is placed in the neonatal intensive care unit, the blood from his umbilical cord revealing over 200 toxins. Where did the system fail Jessica and her baby? How and why did these results occur? 3 years earlier, Jessica had left her parents' house. Access to treatment for her dad's substance use disorder had been eliminated when policymakers closed 3 of the city's public community health centers to save money. Contending with his wife's lack of education, neither of Jessica's parents could secure a job with a livable wage, prompting serious and substantial mental health conditions. Jessica moved to a low-income neighborhood in the city. She never knew of the extent of how the appalling conditions of her neighborhood were politically determined. For example, determined to keep housing segregation in place, politicians expended very few resources to build sidewalks, parks, or recreational facilities. Healthcare providers refused to operate in Jessica's community due to poor reimbursement rates for Medicaid. Because they resisted creating bus routes, lawmakers dissuaded grocery stores from operating in the community, preventing residents' access to fresh fruit, vegetables, and meat. Simultaneously, policymakers altered zoning laws to permit development of a dump site and a chemical plant, switching the community's water source from a clean river 10 miles away to a nearby polluted river to save money. This water was used to drink, bathe, and wash clothes. It also irrigated the lawn at Jessica's apartment building, adding to the list of pollutants and environmental hazards in her neighborhood. And because her district lacked established tenant rights, her landlord had no interest in improving unhealthy housing practices. Jessica found work as a cashier at the corner convenience store, a job with no employee benefits, including health or disability insurance. Because policymakers rejected proposals to increase minimum wage to a livable income, Jessica often substituted her employer's free snacks policy as a meal, never realizing the effect that high-fat, high-sodium food would eventually have on her or her baby's health. With local politicians striking down an effort to ban smoking in convenience stores, Jessica was constantly subjected to a barrage of secondhand smoke. And when she discovered she was pregnant, no attempt at receiving health insurance coverage was successful. Her non-ACA compliant plan denied her maternity coverage because they viewed her pregnancy as a pre-existing condition. Medicaid, the government's health insurance program for low-income families, denied her coverage for not being poor enough. After finding a ride, free clinic, Jessica waited more than half a day to be seen by a second-rate physician, a doctor who was condescending and offensive. Realizing she could not afford to take more days off from work, she never went back. At 31 weeks, a neighbor drove Jessica to a hospital ER 20 miles away. Seeing that Jessica was experiencing excessive swelling in her face and ankles, as well as seizures, the emergency team decided to deliver her premature son immediately. Due to complications, her newborn son was sent to the neonatal intensive care unit. Once his organs were deemed mature enough, he was taken off the machines and sent home with severe cognitive defects. And in their apartment, Jessica and the baby were exposed to mildew and cockroaches, causing her son to develop respiratory problems. The landlord refused to remedy the poor conditions, telling her to move if she didn't like it there. Jessica struggled to find early childhood care and access to schools with educational assistance, healthy food options, and other resources needed to thrive. Because their school and community lacked the resources to enable Jessica's son to even barely reach his potential, he dropped out of school after entering 8th grade, just as his grandmother had done. repeating what is surely the ongoing rule of poverty. Jessica's story shows the compounding effect of political determinants over personal responsibility. No matter how reliably Jessica tried to act, structural, institutional, intrapersonal, and interpersonal obstacles stood in her way. Political determinants were pulling strings that prevented Jessica and her family from achieving optimal health and their full potential. What does this mean for all of us? What can we do to improve and mend our community's most damaged systems?
Thanks so much for that. I'm going to stop sharing now, and we're going to invite you to participate in a couple of polls. So we'll bring those polls up on screen, and would love to hear from you. What are the social determinants of health that you heard operating within that story of Jessica? We'd like for you to think about your local community and which are the ones that you see operating within your community that impact substance use or misuse. And definitely seeing responses of all, noting that all of these social determinants of health are appearing in your communities. We're going to give it another few seconds, so please indicate all of those that you see apply. And we'll set this within the context of part of why we wanted to highlight this video in particular is because while we may look at a community and recognize that the community looks monolithic, maybe from a racial or an ethnic perspective or a linguistic perspective, or maybe even an economic perspective, when we begin to parse out the data and disaggregate the data, separating so that we know not only what are the responses overall, but what are the responses and what are the differences in responses based on gender or sexual orientation or sexual identity or education level or age or even income. When we begin to disaggregate the data, looking at the responses of the population as a whole by different categories, we can begin to understand a little bit more of how maybe some of these social determinants of health may play into the responses. And so what's really interesting about the responses that we see, and I'm going to invite my co-presenters to also jump in, it looks like there are about 2 categories, 3 that have close to 75% or more of you noting that you see this. Economic stability at 77%, neighborhood and built environment at 75%, and then social and community context at 72%. And then we see education access and quality being the lowest rated at 59%, and healthcare access and quality being at the middle at 69%. I will encourage folks to continue to think about this, not only in today's conversation, but in an ongoing way. In all honesty, if we look at our neighborhoods and built environment, that actually is not only where our education also falls in. So the educational access and quality, while many of our communities may bus students to different neighborhoods, there still comes back to the the experience of our libraries present in home communities. Are there other educational institutions available in those home communities, and not just present, but actually accessible to community members? And so that's where we want to encourage you to think about neighborhood and built environment and education definitely being linked, but also what that means in terms of healthcare. I'm located in Boston, and right at the intersection of two major, one is a state road and one is just a main highway, or major road, I will call it, that has hundreds of thousands of vehicles on it each day. Imagine and think about the pollution effects and impacts that exist in my neighborhood. And therefore, what that also means in terms of healthcare access and quality. Boston is known for its hospitals and its medical systems, but if I'm also located in a place where the neighborhood and built environment limit my access to healthcare, or my healthcare access only comes after having experienced significantly, just as we heard in Jessica's story of her and her son in particular, lots of exposures to poisons or just poor air quality, then that has impact, again, going back to education, as well as even then what the social and community context may be. And so want to just encourage you to continue to think about how, regardless of what the overall the overall aggregate data of your surveys and data collection may indicate, there is also understanding how those are impacted by those social determinants. And so we have another question for you, another poll question. So if we'll post that poll question. And this is understanding maybe a little bit more of how the social determinants of health are being addressed by your partner within your coalition. I think one of the things that we've been talking about over the last couple of years is really recognizing the importance of addressing not only having the 12 sectors as part of our coalitions, but really digging deeper within each of those sectors to ensure that we are representing and ensuring representation by partners who address not only some of the other areas that we know are impacted by or impact substance use, but then also are impacting by, by also some of those other areas that we know impact through the social determinants of health. And so hopefully you can see that, that poll question right now. And it looks like you've already responded to that, and that you have, very interestingly, looks like our social and community context is the group that you have the most representation, or excuse me, the majority of you have representation. So, but that's at 48%. And then our lowest rating is with economic stability, and that's 24%. And so I think one of the things that we'll encourage you to think about is to ensure that there's representation of each of partners, not only from those 12 sectors, but also those who are representing and trying to address each of these 12 areas, each of these areas within your 12 sectors. How are some of maybe your education partners also not only present here, but also some of the organizations, the community-based organizations that might be focused on improving educational access? How are they present on your coalitions? As well as thinking about how are some of those organizations that are working to address economic stability present and engaged in your coalitions. And so with that, we want to also, I think, bring this back to recognizing that these social determinants of health are definitely going to have an impact not only on the experience of your broad community as a whole, but they're going to have even more impact, particularly when you begin to look within populations. And so I think if we think back to the image of identity that Priscilla reviewed earlier, if you recognize with that wheel of power and privilege that whether you're a cisgendered male, but if your language is not English as your first language, or maybe you even have a speech impediment, what impact does that have not only with your education, but then maybe with your economic stability? And how does that then play into your potential for or risk for substance use and misuse? And so I want to just kind of encourage you to think about some of those things. I'm looking, just noted something in the question in the chat, but it looks like you're definitely posting some of the questions or some of the comments that are ways that you're reflecting on this. And so with that, I want to transition it over to Shannon, who's going to talk a little bit more about how we can think about bringing in and being sure to address social determinants of health as well with our data in how we plan our prevention efforts. Shannon?
Thanks, Ivy. I just want to pause. Claire, did you have a question?
Well, thanks. We had a question from Lydia about some of the previous slides, asking the question about would public transportation or lack of availability of public transportation be part of the consideration when we're looking at the built environment? And I would think that that's a yes, because it lets you get to places you need to get to. And it lets you have access to other medical and job options, just to name a couple. So yes. Thanks, Shannon.
No problem. Thank you, Claire. And thank you for the question. So thanks, everybody. So as Ivy had mentioned before, we're going to slightly move directions, and we're now in this section going to be talking about diversity, equity, inclusion, implementation in the behavioral health arena. So if you go to the next slide, please. Excellent. So to implement diversity, equity, and inclusion in the behavioral health arena, we use the National Culturally and Linguistically Appropriate Services Standards, or the CLAS standards. The CLAS standards are intended to advance health equity, improve quality, and help eliminate healthcare disparities by establishing a blueprint for health and healthcare organizations. And now we're going to do a quick review of those standards. So if you could do the next click. Perfect. So the principal standard: provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural beliefs and practices, preferred languages, health literacy, and other communication needs. You click again for the second. Perfect. So governance, leadership, and workforce that advance and sustain organization governance and leadership that promotes class and health equity through policy, practices, and allocated resources. The third principle is communication and language assistance. So offering assistance to individuals who have limited English proficiency and other communication needs at no cost, and facilitate timely access to all health care and services. And then the last one, engagement, continuous improvement, and accountability. So establish culturally and linguistically appropriate goals, policies, and management accountability, and infuse them throughout the organization's planning and operation. So since most coalitions and prevention agencies are not considered healthcare, they aren't typically required to follow the national CLAS standards, but there are huge benefits to implementing these standards in community-based organizations. So in these next few slides, we will review how to implement the CLAS standards in non-healthcare agencies, how to provide services, engage with communities, and with community members that you are serving. So now go to the next slide. Thank you. So how do we do this? How do we implement diversity, equity, and inclusion throughout the strategic prevention framework? We start by looking at the role of cultural competency. Cultural competency and the CLAS standards go hand in hand, and it's a core element that needs to be woven into every step of the SPIF. Cultural competence is defined as the ability of an individual or organization to understand and interact effectively with people who have different values, lifestyles, and traditions based on their distinctive heritage and social relationships. It implies an endpoint. I will become culturally competent. But there are many different cultural groups of people, and you can't become culturally competent with everyone. Also, groups have individuals who think uniquely and may not be in agreement with the value or a norm. There is going to be diversity within the group. Cultural humility implies you are never done, and that you being culturally humble with a person, implying that being culturally humble with a person, not just a population of people. So by cultivating both a growth mindset in terms of your own cultural competence and committing to a culturally humble orientation in everything you do, one can then implement the class standards at each step of the SPIF. And we're going to go through some examples how. So next slide, please. Perfect. So in this table, you will see the SPIF steps on the left column, then the class category, the opportunity to apply, and some examples of how to implement that class category. It is possible for each step of the SPIF to have multiple class standards applied, and then this table is just a snapshot of potential examples and opportunities. So as you can see on the screen, for assessment, we have engagement, continuous improvement, and accountability as the class standard. Examples include engagement of key community members to participate in surveys, focus groups, and key informant interviews. And once you have collected the data, it is important that that data is shared back to the key community members who then can be involved in interpreting what that data says. So for example, for our work, one focus population that is very challenging to engage is non-college young adults ages 18 to 25. For college students, it's a little different. You can administer a survey on campus, but how do you engage with 18 to 25-year-olds who are in the workforce? Ideally, you would talk to someone of that focus population, someone who works directly with that population, or potentially both options, to find out where they go and how they get their information. Then start the process of engaging them in key informant interviews or focus groups so they can have a meaningful role in the process. For capacity, we can apply the governance, leadership, and workforce standard. This would mean making sure that prevention staff represent the communities they serve culturally and linguistically. So if you're trying to engage that non-college young adults ages 18 to 25, you want one of your staff members to represent that cohort or be closely related to that cohort. Members of focus populations are meaningfully engaged in the planning and implementation of prevention initiatives and services being offered, as well as offering professional development opportunities to support staff who are working cross-culturally. Next slide. So the next step of the SPIF is planning. And you can see here that the class standard applied is the principal standard. Some examples include having key community members involved in assessing the appropriateness of selected interventions, developing an organizational or community level strategic plan that takes into account the cultural health beliefs and identities of the focus populations being served. We do this by engaging in conversations with members of the focus population. And another project that I'm working on, it's about problem gambling prevention for youth, specifically young men and boys of color. And one of my grantees at the start of the program created an intake form in addition to the permission slip to go home with the youth. In that intake form, there were questions specific to the caregivers of the participants, questions such as preferred language or language spoken at home. So that when the time came to start engaging the caregivers in the activities of that program, the grantee was able to have conversations via phone by using a translation service that would help have the conversations in their preferred language as they had indicated on the form, and getting their full participation and engagement in the program. For implementation, we have on the table you see, we have applied the communication and language assistance standard. So going back to that intake form where they ask for preferred languages. But this also means you can use examples of creating culturally and linguistically appropriate materials to effectively implement strategies. So for example, translating resources and materials, such as study guides for the prevention specialist certification test that our lovely friends at the Hispanic and Latino PTTC have done. In addition to creating study guides, translating study guides, there's also opportunities for testing sites to provide accommodations for people who are hard of hearing or vision impaired while taking their tests. Next slide, please. And finally, we have evaluation. And by applying the continuous improvement and accountability standard, we can develop evaluation tools to gather information from participants about the cultural and linguistic appropriateness of services provided, making corrections and changes based off of that feedback, and then tracking that progress over time. As we implement the class standards, we should see more satisfaction with our services and with a great number of participants who agree that our services are being delivered in a culturally responsive manner. For instance, another project I work on always provides an evaluation survey at the end of every training or webinar. So participants have a chance to provide feedback. And in our evaluation survey, there's always the question of, was this training conducted in a culturally and linguistically appropriate manner? And in this one training instance, we had received feedback that the training was in fact not conducted in a culturally and linguistically appropriate manner because we were using male and female gender signifiers in our case study data, when we should have been using more inclusive gender identities. And because of that feedback that we had received for the evaluation, we were able to review it, go back to the content, change it, and make the appropriate changes to the data set for future iterations of the training. And lastly, by implementing the class standards faithfully and with fidelity at each step of the SPIF, you improve the likelihood of positive outcomes. These are examples of how you can bring the class standards to life. And when thinking about sustainability as a guiding principle, any efforts you make to sustain class standards also contribute to the sustainability to positive outcomes. By implementing class standards, your organization is taking steps to provide equitable and sustainable prevention services. And I know that was a lot of information rather quickly, and it was more of a snapshot of what it can look like. But I do want to note in the resources that we've provided with this webinar, we do have the National Class Standards Implementation Checklist, which is available for you to use to help with your implementation efforts. And I'll walk you through step by step on how to do that. And on that note, I'm going to hand it over to Christina.
Thank you, Shannon. So a really important element of diversity, equity, and inclusion in community-based prevention is ensuring that the work is actually community-led. So prior to me joining the National Hispanic and Latino PTTC, I had the privilege to work with the Hispanic and Latino community in New Bedford, Massachusetts, which is where I live. And I worked alongside the community to develop culturally and linguistically appropriate prevention programming. As part of this work, I developed this framework that you see on the slide. So just some background, the acronym CAEL stands for Centro de Ayuda y Esperanza Latina, and they are a small nonprofit here in New Bedford that supports the local Hispanic and Latino community, and that's where this work occurred. So while this framework was created by and for the Hispanic and Latino community, the elements are really universal and can be beneficial to any population. So this framework has 5 steps. Keep in mind that these are not linear by any means, and they can actually be repeated or skipped depending on the needs of the community. In communities where assessment is regularly done as part of the ongoing work, or there are already strong relationships, for example, there may be less emphasis placed on these steps of the framework. But keep in mind that this framework is not specific to substance misuse, but it can really be applied to any issue where community engagement is prioritized. So the 5 steps of this framework are assess, which is assessment of the community, trust, which is relationship building with community brokers, organize, which is community organization and development, implement, which is implementation of community-led strategies, and evaluate, which is for evaluation of progress and planning for quality improvement. What I have found over the last year or so of discussing this framework with different professionals and communities across the country is that one of the biggest barriers to community-led prevention is building trust. So that is what we're going to focus on over the next few slides. Next slide. So cultural brokers serve as a bridge between one community and another. I've also heard the term gatekeeper, but I try to avoid that term as much as possible because it gives off a negative image, at least for me, of someone trying to keep others out. Cultural or community brokers feels much more inclusive. So on this slide, there are some examples of who cultural brokers are, what they bring, where they can be engaged, and how their experience can support the goals of the community. In my own experience, I've worked with Hispanic and Latino faith leaders around the issue of substance misuse, and they have held community forums where I've been able to educate community members, receive community feedback. I was able to be informed of the issues they were facing and was able to identify potential solutions through community conversations. Building relationships with trusted leaders in the community is key to engaging the community in an authentic way. Next slide. So intentionally bringing diversity, equity, and inclusion in many levels of our work is really important. Here, we're not just talking about our staff, but also leadership, advisory council members, coalition leaders, coalition members, etc. So there's some things to consider. So who's missing at the table? Is the community you're hoping to reach represented? Census data might actually be really helpful to determine the groups with a presence in your community and ensure that they're represented. A lot of times we as community leaders have assumptions that we hold about who makes up our community. And it's not always what we think it is. So it's always great to be able to go back to the data and use that to guide the process. It's also really important to try to ensure that tokenism isn't an issue within your agency or coalition. No one person represents an entire population. So it's important not to put that expectation on an individual or a smaller group of individuals. Also, try to avoid overgeneralizing a population. Subpopulations are diverse and complex, and population-based assumptions about that group can often push us to overgeneralize. We see this a lot in the Hispanic and Latino community. There are a lot of beliefs around our community and our culture that if you look at one region to another, we are very different and we are very diverse. So it's just some things to keep in mind as you go through this process. Next slide. So I know when a lot of people are doing this work at the local level, they often wonder how to even start, how can they go about building trust, especially across cultures. One of the biggest recommendations I can offer you is to go to where the people are. A lot of times people in positions of power expect the people to come to them, but honestly, that typically doesn't work very well. You'll want to hold activities where people are already going or where they feel comfortable. Ask the hard questions. You'll maybe feel uncomfortable with some of the answers that you get, but it really is important to clear the air in order to move forward as a community. Be transparent. In my experience, people can tell you, they can tell when you're being genuine. You don't need to have all the answers, but be honest when you don't know and let them know that you'll find out and you'll follow up. And provide opportunities for community conversations to occur. When you provide spaces for the community to come forward and share what is going on, they often will. It may take a few tries, but eventually word does get around and these activities will grow. You may be surprised with who wants to show up. We did a series of community forums where we had these conversations. And we had state representatives, school superintendents, the health director, and other officials asking to attend. And it was a great opportunity for the community to advocate for their own needs and to know who they need to go to in the future when a problem arises. Next slide. So as we already talked about, fostering relationships with community allies is really helpful to reach the larger community. If you're kind of unknown to the community, if they see you working with someone they already trust, they're much more likely to open up to you. Also, don't get too hyper-focused on your goals and deliverables. While the issue you are working on is important, there may be other issues that are more important to the community in the immediate time frame. If you ask about their needs and concerns more generally, not just specific to the work that you're doing, it will help to build trust long-term. If their needs are not in your area of expertise, you can still connect them to local services that can help them. If you do make some sort of promise to the community, just make sure you follow through with it and keep them informed so they know you didn't just forget about them. There are going to be situations that arise that you try your hardest to address or to connect them to the right people, and there are barriers. Just be honest about that with them. Explain to them what's going on, and you, along with the community, can try to come up with some sort of solution, but at least they see that you are really trying, because that's going to help them to trust you more. Next slide. So when we start assessing and asking these questions, we may think that we're doing something wrong or we're not doing something that we should be doing. It's not really about that. It's about the journey. And we really invite you to start thinking about the path. So how do we recognize privileges, including the ones we experience? Once we understand that, we will be better prepared to appreciate the experiences of those who may not share the same privileges we do. We can start learning how to be comfortable with being uncomfortable. And when we sit with the uncomfortable, we have a tendency to grow. We can develop our cultural competency when understanding, appreciating, and interacting with people from cultures or belief systems different than our own, and move forward to reach humility, which is a lifelong process of self-reflection and self-critique, to not only learn about another's culture, but to start with an examination of our own beliefs and cultural identities. This process helps us to overcome personal anxiety, assumptions, shame, guilt, and fears we often have when approaching issues of disparities. This process also helps us to consider where people might be at in terms of their own feelings when talking about diversity, equity, and inclusion. People can feel a lot of guilt and shame around these issues because of the level of awareness that has been raised, especially around privilege. Next slide. So we mentioned earlier, this session was a follow-up to a presentation we offered at the NPN virtual conference in August. We are also going to be offering 2 follow-up technical assistance sessions for those people looking to dive deeper into this content and figure out how to actually implement it at the local level. There is limited availability to participate in the 2 sessions, which will be held on March 2nd and March 16th from 2 p.m. to 3 p.m. Eastern Time. So anyone that is interested should view the recording from that NPN session if they haven't already, and submit their application through SurveyMonkey. I'm going to ask that one of my colleagues put the links in the chats. And please keep in mind that these applications are due by close of business on Thursday, February 23rd. There will also be an email that goes out following this webinar, and we'll make sure those links are available there as well. And so now I believe we are going to open it up for any questions for the next 10 to 15 minutes.
I see one of the questions right now, Christina, is if there is any cost related to these technical assistances that we will be offering? And the answer is no, they're totally free of cost to you all. So we definitely encourage you to apply and submit your application. One of my colleagues will also be sharing the evaluation link in a few minutes. So we definitely ask you to complete the survey with your opinion. Your feedback is very important for the work that we do, helps us to understand how we can improve our training efforts, how can we serve you better, and also is the proof to our to SAMHSA that we deliver the trainings and we are fulfilling our deliverables. So we please ask you to complete the GIPRA. It does not take more than 5 minutes.
And we will be sending out, we have some folks asking, yes, we will be sending out to everyone that has attended, we will be sending out the slides, and we'll also be sending out the reporting. I'm sorry, a couple of people have said that they had some difficulty with the Zoom, that they could hear but could not really see. They were having some tech problems, and we regret that. I'm sorry about that.
Christina, I think that is a question for you from Amanda. Amanda, I hope your dogs are okay. I think you joined saying that they were a little bit agitated in the beginning, but we were safe. You were muted. Thank you for joining us today. The question is, in a smaller scale than a whole community, but she's curious to understand how can you gain trust with a group that knows you are trusted by others, they see your work, but they are still reserved in their own groups to trust you?
So my suggestion would to just have that conversation with them. Ask what it is why there's an issue with trust, because sometimes it's perceived. Sometimes like you may think they don't trust you, but it could be something else that's going on. Sometimes it's the agency you represent. That has been an issue for me and other agencies, where I wasn't so much they didn't trust me, they didn't trust who I worked for. And that's a lot of that information will help you to determine, okay, is it an issue that I can solve myself, or do I have to do some almost like cultural brokering between my agency and this community? But until you have those answers, I don't think you'll be able to really figure it out. It takes some vulnerability to put yourself out there in that way. But I think it's definitely worth trying.
Thank you, Christina.
The only thing I'd add with what you just shared, Christina, is this is where it's important to know the history of a community and history of organizations. And that's where you'll begin to understand a little bit more of some of those kinds of things.
What I'm gonna do is I will move forward with the slides just so we can complete this portion of the session. We stop recording and then we open up for additional questions if you have any more. The references of the information that we use to compile this presentation is here. You're gonna receive a copy of this presentation in a PDF. You can access these links and learn more. If you want, we're also including some resources and tools. Some of them were mentioned throughout this meeting. Some of them we were not able to share with you, but we definitely want you to have those links and access that information as you go. If you need more information and you want to request training, technical assistance to our centers, we have our contact information here for the National Hispanic and Latino PTTC. We have Facebook, LinkedIn, Twitter account, and we keep up. We keep all of our upcoming events there so you can take a look on them. And we do appreciate you taking the time to join our session today. We hope that you have a lovely rest of your week. The weekend is nearly here. We thank you. Gracias. Obrigado.